Good afternoon, everyone. Center of Excellence at Bowring and Curzon Hospital, Bangalore welcomes all the participants for today's RDLS session. Today's topic is HIV and OI, CNS. We'll be covering this topic in two sessions. The first one is conducted today. The next session will be held on next Friday, 17th April from 2 to 3 p.m. Question answers will be taken at the end of the session. We have with us today Dr. Arvind sir. Dr. Arvind sir is the professor and head of the Department of General Medicine and the program director of the Center of Excellence in HIV Care at Bowring and Lady Curzon Hospital, Bangalore. He brings in 2 decades of extensive experience in healthcare and has authored numerous papers in both national and international journals. We welcome you, sir, for today's session and request you to start the session.
Thank you. Warm welcome to all the participants. Now, let's start the session without wasting any further time. So this is about introducing, see what we, as Shweta has put it, we have divided into 2 parts for, it's better convenience for all of us. So I would be taking up till toxoplasmosis because that involves quite a lot, and the next session will cover majority of the other things. So now, keeping the starting the program, we're introducing to the opportunistic infections, the background. We go about common symptoms and signs, various opportunistic infections based on presentation in different systems, and common diagnostics and treatment related challenges of the OIs. So, what is the definition of OI? An OI is a disease caused by microbial agent in a person with a compromised post-immune system. Acquired immunodeficient virus or syndrome is defined as the occurrence of life-threatening OIs, malignancies, neurological disease, and other specific illness in patients with HIV infection and CD4 counts less than 200 cells per mm cube. So OIs are the major cause of morbidity and mortality among people living with HIV. So early diagnosis of HIV status and periodic interaction with the people living with HIV are needed for providing appropriate preventive advice and for timely management of OIs. Screening for the OIs in persons at risk, particularly before starting ART, will reduce the incidence of iris. It's everybody, I'm sure, knows about iris. Immune reconstitution, inflammatory syndrome. Judicious use of chemotherapy and immune prophylaxis to prevent various OIs favorably impact the survival of PLHIV. In a systematic review, ART led to greatest reduction in incidence of all OIs during the first 12 months of ART in the range of 57 to 91%, except for tuberculosis, and was the largest for oral candidiasis, PCP, and toxoplasmosis. So the incidence of OIs, so it depends mainly on the level of immunosuppression occurring at CD4 cell counts of less than 200, as I mentioned earlier. Then endemic prevalence of the causative agent. So patients with CD4 counts less than 200 depends on the status of immune system or immune suppression within the patient, and the area which is whether it is endemic or non-endemic for that particular causative agent. So classification of OIs based on CD4 levels. So if you look at the graph, even at the highest CD4 cell count, you have Mycobacterium tuberculosis being as one of the OIs. And around the same is the bacterial pneumonia, HSV zoster, diarrhea, then comes the oral candidiasis, then your below 200, around 200 or below 200 is your PCP pneumonia, Kaposi sarcoma, cryptococcal meningitis, toxoplasmosis, non-Hodgkin's lymphoma. So primarily, if you look at it, All the CNS manifestations and infections are vulnerable if the CD4 counts are less than 200. So, with people, what are the proportions? Which OIs are more common in people living with HIV? As we can always safely say, tuberculosis is one of the most common OIs. Next comes the oral candidiasis, diarrhea, herpes zoster. In this range, now bacterial pneumonia is one of the least that you can suspect among people living with HIV. Primarily, tuberculosis is very rampant and standing at 56.7%. Now we're talking about cryptococcal meningitis, BCP pneumonia, and majority of them are little undiagnosed also. So I think the criteria is emphasis is laid on early diagnosis and managing the CNS manifestations. So presenting symptoms and signs among PLHIV, majority of them present with fever, weight loss, cough, dyspnea, lymphadenopathy, diarrhea, abdominal pain, asthenia, skin lesions, night sweats, chest pain, altered sensorium, hemoptysis, seizures. So majority of them come with fever and weight loss, which you should suspect immunodeficient syndrome. So what is important for you to know? So strategies for diagnosis of OIs is one. After you diagnose, management is the other thing. Then the timing of initiation of ART in the presence of OI, because iris have to be countered. Recommendations during pregnancy, understanding the geographically distinctive OIs like penicillinosis and leishmaniasis, drug interactions during concomitant administration of treatment of for OIs and ART. So this is the classification based on the pathogens that are infesting people living with HIV. Now, bacterial, viral, fungal, and parasites. Bacterial, predominantly tuberculosis, viral, varicella zoster, herpes, cytomegalovirus, human papilloma virus, Epstein-Barr virus, JC virus, fungus, candidiasis, PCP pneumonia, cryptococcus, histoplasma capsulatum. Parasites are toxoplasmosis, very important. Intestinal parasites like cryptosporidium, chronic diarrhea, you can suspect isospora, microspora, giardia. So various and so on. So various opportunistic infections based on the presentation in different systems. So if it is respiratory system, then tuberculosis, we are looking at Mycobacterium tuberculosis, bacterial pneumonia, PCP pneumonia, Mycobacterium avium complex, Toxoplasma gondii, Penicillium marfani, histoplasmosis, GI system, candidiasis, necrotizing gingivitis, HSV lesions, Epstein-Barr infection, Kaposi sarcoma, aphthous ulcers, and esophagitis. And oral candidiasis, as I mentioned, which is very uh, characteristic feature of immunodeficient syndrome. So, central nervous system, toxoplasmosis, cytomegalovirus, bacterial meningitis, tubercular meningitis, progressive multifocal leukoencephalopathy. That is also very important, and neurosyphilis. So, skin and mucous membranes, Staphylococcal aureus, bacillary angiomatosis, lupus vulgaris, cutaneous manifestations of syphilis, candidiasis, tinea infections very predominant, systemic mycosis, Kaposi sarcoma again, herpes zoster, so on. Uh, so, what are the common diagnostics and related challenges of OI infections? So, tuberculosis, possibacillary TB forms, and atypical clinical presentations of disseminated TB and poor sensitivity of existing screening tests available, especially in people living with HIV with CD4, lower CD4 counts. Difficult to get a good clinical specimen from extrapulmonary side to rule out disseminated tuberculosis. Facilities for diagnosis of extrapulmonary tuberculosis are not present in all ART centers like ultrasound and ophthalmoscopy. Candidiasis, non-availability of referral facilities like endoscopy, PCP pneumonia, usually diagnosed clinically, hence there is an ongoing need to train medical officers to enable and suspect and accordingly manage PCP. Cryptococcal meningitis. Now, CSF collection has to be done. It should be trained and done in a tertiary care where LP is done, and CBNAT facilities have to be available, and so in aseptic precautions. So, and also you have to differentiate between new and relapse cases as culture testing is not available everywhere. Toxoplasmosis, again, brain imaging have to be done, and subject them for LP, wherein CSF analysis have to be done. And as the early diagnosis, all these opportunistic infections diagnosed early, treated early, will give a different prognostic picture. Now, chronic diarrhea, as I said, CME retinitis. So treatment related challenges, long duration, follow up is a big challenge. Also drug reactions, and and patient compliance to the drugs for a longer time. Non-availability of certain drugs to manage OIs at the ART center. So could also be one of the challenge, but that's for them to look out. So central nervous system. So we're starting with the introduction. HIV is a neurotropic virus and has a predilection to infect the nervous system. So as a virus, whether your CNS system is infected or not, there will be some characteristics of infection of your nervous system. So HIV affects the nervous system in two ways: directly by the neurotropic effects of the virus itself, and secondly with the opportunistic infection of the nervous system. So any level of neuro access can be involved, including the brain, meninges, spinal cord, nerve, and muscle. Neurologic disease is the first manifestation of symptomatic HIV infection in roughly 20% of the people, whereas 60% advanced disease will have clinically evident neurologic dysfunction during the illness. So majority 60% in advanced HIV patient, the neurological dysfunction is relevant and pertinent during the entire course of illness. Clinical manifestation of HIV. HIV related acute aseptic meningitis, chronic meningitis, HIV associated neurocognitive disorder, in short we call them as, and HIV encephalopathy, AIDS dementia, vacuolar myelopathy, peripheral neuropathy, and myopathy as well. OI related because of HIV, which is also called as immune deficiency syndrome. This syndrome is a complex of opportunistic infections causing various manifestations. From through cryptococcal meningitis, cerebral toxoplasmosis, CMV retinitis, encephalitis, progressive multifocal leukoencephalopathy, primary CNS lymphoma, tuberculosis, syphilis, and so on. So, what are the clinical features of various parts of the CNS system involvement? Now, for example, if meninges are involved, headache, fever, and nausea are dominantly the most important clinical features. What are the etiology can be tuberculosis, coccosis, syphilis, and other bacterial. Now, focal cerebral lesions, it could be involving basal ganglia, it could be involving your thalamus. So it could be toxoplasmosis, progressive multifocal leukoencephalopathy, tuberculoma, multiple CNS lesions, primary CNS lymphoma, neurocystosis. Now, if it is encephalitis, cognitive impairment, psychiatric features, altered sensorium, convulsions, primarily caused by HSV virus, cytomegalovirus, and toxoplasmosis. If it is myelitis, involving the spinal cord, sensory disturbances, paraparesis, sphincter disturbances, again caused by CMV, HSV, syphilis, toxoplasmosis, tuberculosis. Neurocognitive decline, memory loss, dementia, behavioral abnormalities. So, various other important characteristics of CNS infections. Coming to cryptococcal meningitis. So, after we laying a foundation thing about what clinical features to expect from various infestations, we are talking about cryptococcal. What is epidemiology? Cryptococcal disease is an opportunistic fungal infection that occurs primarily among people with advanced HIV disease, caused by the encapsulated yeast of Cryptococcus neoformans or Cryptococcus gattai. Cryptococcal antigenemia is considered an independent predictor of cryptococcal meningitis in PL-HIV patient with advanced immunosuppression. So, even with good immunosuppression, cryptococcal antigenemia can be isolated and one of the primary early independent predictor of cryptococcal meningitis. Cryptococcal meningitis accounts for an estimated 15% of AIDS-related deaths globally. That's a very significant number. A major reason for this high mortality is delay in diagnosis. As I said, antigenemia, cryptococcal antigenemia is early marker, and if you isolate antigenemia with CSF Craig negative or positive, you are assuring the patient of a good prognosis, largely because of the limited access to the lumbar puncture and rapid diagnostic assess. Only these are the two setbacks. If you are able to identify in the serum, then the prognosis will be much better. So, what are the clinical manifestations? One is your subacute meningitis or meningoencephalitis. Then they develop non-specific symptoms consisting of fever and headache. They Most of them do not have classical signs, and that's why identifying them becomes a very challenging. So you will have to rule out meningitis in the form of headache, fever, and all that meningeal irritation early in the course of meningitis. As the disease progresses, more neurological specific manifestations typically develop, including altered mental status, neck stiffness, or cranial nerve abnormalities. Now we are talking about advanced stage, wherein the patient may even succumb at that stage because in advanced HIV infection with CD4 count less than 200, possibly the multi-system involvement is there, and the CNS manifestations are very uh, dominant. So cryptococcus coccosis usually is disseminated when diagnosed in HIV infected patient. Test for the diagnosis of cryptococcal infection. Now, as I said earlier, serum or CSF, microscopy in CSF, culture also through CSF. So now, Craig test is currently not available in the program, as the slide is also mentioning. India ink staining of CSF demonstrated encapsulated is in 60 to 80% of cases. So CSF analysis mildly elevated levels of protein, low to normal glucose concentrations, and pleocytosis consist of mostly lymphocytes. Opening pressure in the CSF is usually high in such patients, greater than 25 centimeters of water, occurring in 60 to 80% of patients. For PLHIV suspected of having cryptococcal meningitis, prompt lumbar puncture with measurement of CSF opening pressure and rapid crack assay is recommended as the preferred diagnostic approach. The diagnostic approach is recommended based on the availability of the testing facility. Okay, settings with access to and no contraindication for lumbar puncture. Okay, so Craig assay is available. Lumbar puncture with rapid Craig CSF Craig assay is done. Craig assay is not available. Lumbar puncture with CSF India ink should be done. Settings without access to lumbar puncture, and when lumbar puncture is clinically contraindicated, then you can take serum Craig. And if Craig assay is available, if it is not available, prompt referral for further investigation and treatment in an appropriate center. So you have to ask, look, and investigate for cryptococcal meningitis. You have to do all that within your purview to make sure that you arrive at the diagnosis as early as you can. Ask for onset of symptoms suggestive of meningitis. Do not miss any non-specific symptoms. The patient is on ART. Ask the duration on ART to rule out iris. Look for the implication to differentiate between molluscum and cryp- cryptococcoma skin lesion. So you'll have to look for the implication. The peduncles attached to the skin. So look differentiate between molluscum and cryptococcoma skin lesions. Now, serum Craig is indicated in all people living with HIV, presenting with CD4 counts less than 200 cells. So, less than 200 cells, you are doing Craig serum in all patients with or without symptoms suggestive of cryptococcal meningitis. Whether he has symptoms or no, you are going to do it. In patients presenting with symptoms like severe headache while on cryptococcal meningitis treatment, therapeutic CSF tap is indicated. Make a note that it should be done in a very sterile environment and so that no infection is introduced. Refer all patients with positive serum Craig for lumbar puncture. A negative result on India Inc. does not rule out cryptococcal meningitis. So screening and prevention, screening for Craig followed by preemptive antifungal therapy among Craig positive patients to prevent development of invasive cryptococcal disease is recommended under the national program. Before initiating or reinitiating ART for adults and adolescents living with HIV who has CD4 count less than 2. Screening is not recommended for children less than 10 years. Ah. No, we are not. So I spoke in the morning to some people. They said they are in talks with this. So anyway, given the low incidence of cryptococcal meningitis in this age group, Craig LFA is reliable, robust, and easy to perform, and should be used to diagnose cryptococcal infections among PLHIV. It is recommended to use it in any PLHIV with CD4 counts below 200 cells. Okay, now what are you going to do with if the CD4 counts are less than 200 with symptoms of meningitis? Interpretation and management based on Craig in PL in patients with CD4 counts less than 200. Craig positive, serum Craig positive, CSF Craig positive. Treat as cryptococcal meningitis protocol. Serum Craig positive, negative or not feasible. You're not able to do CSF or it is negative. So, if symptomatic, treat for cryptococcal meningitis. If it is not symptomatic, preemptive treatment should be initiated. If it is negative and the patient is symptomatic, consider evaluating other causes, ruling out other causes. If asymptomatic, standard package of care. You are not able to do any of this serum or CSF, then patient is symptomatic, consider evaluating for TB. Whatever that is there within your means, make sure you rule out, and then probably consider presumptive treatment for cryptococcal meningitis or bacterial meningitis, or refer a patient where LP is done and you are able to assess the patient in a better care. If it is asymptomatic, then fluconazole as a primary prophylaxis, if the CD4 count is less than 100, is initiated. Offer preemptive antifungal treatment if asymptomatic PLV test positive for cryptococcal infection. So, antifungal treatment is preemptively started in asymptomatic patients in HIV patient, irrespective of their CD4 count status. Everyone testing positive for serum or plasma, Craig during the screen should be carefully evaluated for signs and symptoms of meningitis. The preemptive antifungal treatment is recommended in pregnant women as well. However, proper counseling should be provided. So, this preemptive treatment is divided into induction phase, consolidation phase, and maintenance phase. In induction phase, what should you do? It is fluconazole 800 mg per day for 2 weeks you have to give. In consolidation phase, 800 mg of fluconazole for 8 weeks you have to give. For 8 weeks, you have to give fluconazole of 800 mg every day. If in maintenance phase, you have to give 200 mg. Till when should you give? Till the patient CD4 count has improved beyond 200 and he has successfully taken ART regularly for 1 year. Immediate ART initiation is not recommended for patients, for adults, adolescents, and children living with HIV who have cryptococcal meningitis because of the risk of iris, which I already mentioned. So it is deferred by 4 to 6 weeks. A patient is diagnosed with cryptococcal meningitis, he is on treatment. So ART treatment is put on hold for 6 weeks to avoid iris. 4 to 6 weeks is put on hold from ART regimen. Yeah. So you will have to make sure iris is much more detrimental than the opportunistic infection itself, because inflammatory reaction will be so high, the patient may succumb to the iris. Thus, ART should be initiated between 4 to 6 weeks after successful antifungal treatment. After what successful antifungal treatment? After initiation and consolidation phase. Primary prophylaxis not recommended because uh, relative infrequency of cryptococcal disease, lack of survival benefit associated with prophylaxis, possibility of drug reactions, potential antifungal drug resistance, and cost. If Craig test is not available, primary prophylaxis may be given to HIV positive patients and adolescents who have CD4 count less than 100. So if the CD4 count is less than 100, primary prophylaxis is, yeah. So we are is initiated if the cell count, CD4 cell count is less than 100. The recommended dosage, as I said, it is fluconazole 100 mg one only. Right? Criteria. So criteria for discontinuing fluconazole as primary prophylaxis, please make a note. It is very important. All the following criteria have to be met. Person is adherent to ART and free of cryptococcal disease. Fluconazole is given for at least 1 year. CD4 count is greater than 100 cells. Viral load should be suppressed to less than 1000 copies per ml. So in proven cryptococcal meningitis, what is the induction phase? Amphotericin B deoxycholate 1 mg per kg per day and flucytosine 25 mg per kg 4 times in a day for 1 week. Followed by fluconazole 1.2 grams up to adolescents up to a maximum of 800 mg per day. So it is 1200 mg per day in adults and 800 mg per day in children for 1 week. Now, alternatively, what you can give 2 weeks of fluconazole, the same strength, and flucytosine. In case amphotericin, which is B, which is very expensive and may not be available. Another alternative is 2 weeks of amphotericin B and fluconazole of 1.2 grams in adults and 800 mg in children. So that is your induction phase. The consolidation phase is fluconazole up to a maximum of 800 mg daily for 8 weeks. Maintenance, if fluconazole 200 mg daily for daily. Now maintenance, I'll tell you when you can discontinue. Only till then you have to give. When can you discontinue? As I said, person is adherent to ART and free of cryptococcal disease. is adherent for at least 1 year and fluconazole maintenance treatment given for at least 1 year. CD4 count should be more than 100 cells and viral load should be suppressed to less than 1000 copies per annum. So what madam also is of the opinion, if you see any recurrence of cryptococcal meningitis, it is because of the shortcomings in the treatment itself. So many times the maintenance dose is not maintained. Now 200 mg for over a year is not given, and patients we have seen the coming back with recurrence of uh, cryptococcal meningitis, and also it is discontinued sometimes when CD4 count is less than 100. You have given, may have given for a year, but CD4 count has not improved. Its viral load is more than 1000 copies, and you have stopped fluconazole thinking you have given for 1 year, which is not ideal. So you have to keep all these considerations in mind and execute the discontinuation phase. So, special recommendation, managing raised intracranial pressure. If the opening pressure is elevated, the recommended approach is to remove ample CSF to reduce the opening pressure to a normal pressure. So by at least 50%, forget all the mLs that we are talking about, the opening pressure should be reduced at least by 50%. See, one is for that serial lumbar punctures are indicated, then shunts are indicated, like lumbar drain is indicated, ventriculostomy is, if required, is done, and for persons with acute cryptococcal meningitis, attempts to treat increased ICP with medical therapy such as mannitol, acetazolamide, and corticosteroid is not effective and is not recommended. So, administration of amphotericin B deoxycholate. Liposomal amphotericin B is preferred over conventional amphotericin B for primarily because of less side effects and better toleration by the patient. Now, amphotericin B powder should be reconstituted in sterile water. Add calculated volume of reconstituted antifungal to 1 liter of 5% dextrose so that there is no thrombophlebitis and there is no other kind of infections. Now, after the amphotericin B, it is there is the peripheral in IV line should be administered with solutions containing 1 ml of 5% dextrose water so that thrombophlebitis is avoided. This solution should be infused over 4 hours. I mean, talking about amphotericin B solution should be infused over 4 hours. Adults should be pre-hydrated of 1 liter normal saline before 1 ampule of potassium chloride they have to be pre-hydrated with 1 liter of normal saline containing 1 ampule of potassium chloride infused over 2 hours before the amphotericin B administration. Twice daily oral potassium and daily oral magnesium supplementation should be administered to adults. To minimize the risk of phlebitis, line should be flushed with normal saline immediately after amphotericin B infusion is complete, and the infusion bag should not be left attached even after the administration of the infusion is over. So monitoring the patients receiving amphotericin B, days 0, 3 and 7, check for creatinine, sodium and potassium levels. 0 and 7, full blood count with differential count should be checked. Management of amphotericin B related toxicities, febrile reactions can be treated with paracetamol and hydrocortisone can be given in severe adverse anaphylactic reactions. Now, relapse of cryptococcal meningitis. So, what is, as we mentioned earlier, the causes are inadequate induction phase of the therapy, suboptimal amphotericin B deoxycholate administration because of toxicity, non-adherence to fluconazole consolidation or maintenance therapy, fluconazole resistance itself, which is uncommon, but if preferred induction regimens are used. The central nervous system cryptocomas or gelatinous pseudocysts requiring prolonged induction therapy. immunological failure because of virological failure of ART. So ART failure, now the regimen that the patient is on itself is not yielding good results in the form of viral load more than 1,000 copies, CD4 count less than 100 itself is one of the cause for relapse of cryptococcal meningitis. So as you mentioned about iris, features of iris, most cases have negative CSF fungal culture, occurs weeks to months after ART initiation because of an inflammatory response directed at antigens of non-viable fungus. Associated with higher CSF white cell counts compared to the initial culture positive episode of cryptococcal meningitis, frequently accompanied by raised intracranial pressures. So, in all patients with suspected paradoxical cryptococcal meningitis iris, a lumbar puncture should be performed to measure pressure and obtain a fungal culture incubated for up to 14 days. So, other etiologies of relapse. Now we're talking about unrelated to cryptococcal meningitis is your tuberculosis meningitis, viral or bacterial meningitis, space-occupying lesions in the form of tuberculoma, malignancies, non-infective like tension, headache, so on and so on. So it's a screening and management flow chart wherein you screen for tuberculosis, persistent headache, fever, altered sensorium. Then you look at signs of serious illness. You look at temperature, respiratory rate, heart rate, and so on. Now that is all assessed by the nurse, and then medical officer takes over. So with none of these, then the presenting symptoms, if it is confusion, headache, fever, stiffness, and photophobia, then you have to look for Craig serum antigens. Then and if these symptoms are not there, then you go further on to assess symptoms of meningitis. And if it is still not there, then interpret CD4 count results last 3 months. Then if the CD4 count is less than 200, perform serum Craig. The serum Craig is positive, then uh, look for to perform LP to confirm cryptococcal meningitis, and so on. So here also, if the symptoms are positive as per the sister, then look to refer to a higher center to confirm. Of course, they're all HIV patients, to confirm with LP, the CSF, Craig, and CBNAT, so X-rays, and look for any disseminated infections also. So coming to toxoplasmosis. So toxoplasma encephalitis is caused by the protozoan Toxoplasma gondii. Transmission occurs by eating food contaminated with oocytes from cat feces or from tissues in undercooked meat from domesticated animals. Toxoplasma infection remains the most common cause of focal brain lesions among PLHIV. So it's a rare among patients with CD4 count more than 200 cells. Patients with CD4 count less than 50 cells are at higher risk. The organism is not transmitted through person to person contact. So what are the symptoms? Headache, confusion, and motor weakness with fever. Patients may also present with non-focal manifestations, including only non-specific headache and psychiatric symptoms. Focal neurological abnormalities may be present on physical examination. In the absence of treatment, disease progression results in seizures, stupor, coma, and death. CT scan or MRI brain will typically show multiple contrast enhancing lesions in the gray matter of the cortex, basal ganglia, and often associated with edema. You can see the MRI of multiple toxoplasma in the brain. Serum IgG and IgM of antitoxoplasma antibodies do not indicate active disease. PCR tests have high specificity and but low sensitivity and are not easily accessible. CT or MRI scans showing focal lesions may be helpful in making the diagnosis. Lesions are usually ring enhancing and have a predilection to the basal ganglia. No imaging technique is completely specific. So, what do you look for that in toxoplasmosis? Headache, confusion, stupor, convulsions, and neurological deficits. So, what are the DDs that you can think of? The DDs that you can think of is CNS lymphoma, progressive multifocal leukoencephalopathy, tuberculomas, uh, the neurocystocercosis, and so on. So, PML lesions typically involve white matter. So, you have to look at progressive multifocal leukoencephalopathy is one of the DDs, but they involve primarily white matter than gray matter and are non-contrast enhancing and produce no mass effects. In toxoplasma gondii, there will be a mass effect. Their predilection is to the basal ganglia and not the cortex. So, less common causes of focal neurological diseases in patients with HIV include mycobacterium infection, fungal infections such as cryptococcosis, Chagas disease, and pyogenic brain abscess, particularly in IV drug abuse. So, coming to the management, pyrimethamine 200 mg per oral once, followed by dose based on body weight. So, pyrimethamine, sulfadazine, leucovorin, and the body weight is more than 60 mg. Now, the dose is different. So, uh, the another alternative treatment is cotrimoxazole, trimethoprim sulfamethoxazole, which we also give it as a primary prophylaxis. So, this is a preferred regimen: pyrimethamine, sulfadiazine, and leucovorin. Alternatives is clindamycin, leucovorin, pyrimethamine, or trimethoprim sulfamethoxazole double strength single tablet twice daily or trimethoprim sulfamethoxazole double strength one tablet once a day. So discontinuing chronic maintenance therapy. Patient who has successfully completed initial therapy remains asymptomatic of signs and symptoms of toxoplasma encephalitis. CD4 greater than 200 cells. So greater than 200 cells, you have to think about discontinuing the treatment for toxoplasma gondii. Prophylaxis of toxoplasma encephalitis is classified as either primary prophylaxis or maintenance therapy. CPD protects PLHIV from PCP, toxoplasmosis, and other bacterial diseases. The double strength tablet once daily dose of cotrimoxazole, which is the preferred regimen for PCP prophylaxis, is also effective against toxoplasma encephalitis and is recommended. In case of allergy to cotrimoxazole, an alternative for primary prophylaxis against PCP and toxoplasma, dapsone is used 100 mg once daily. Desensitization may be suggested for sulfa allergy. So we'll start from cytomegalovirus in the next sessions. I think we have covered around 60 slides. We have another 50 to go. Probably next Friday we should be able to. And my recommendation, see, for early marker for cryptococcal, take this opportunity to involve everybody who's present, including Shweta. See, we are, we have written a mail. We are seeking some kits for Craig, serum Craig diagnosis, so that we start with the early treatment of people who are cryptococcal, infested, and the
Right.
outcome would be much better rather than waiting for them to have a CNS manifestations and then finding out through LP. So Craig in serum is the early marker. So I would really request all the concerned people to expedite the process and give us these kits so that at least Center of Excellence will initiate, and we'll see how far we can go with this.
Right, sir.
We have addressed this mail to NACO, CASEPS, and all the parties who are concerned. Since we're doing the same, dealing with the same topic for today, I thought probably I'll take this opportunity.
Yeah, so we may not have people from SAGS or
I
NACO
know,
who are
I
there
know,
in
I
the
know,
session,
I know,
but
I
I'll
know.
I'll pass on the numbers to you. Is that okay?
Yeah, that should be okay.
I'll do that, sir. Yeah, any questions so far? We'll be covering the remaining part on Friday. So I'll contact you before circulating the flyer on Friday.
Great. That
Right?
would be nice. Yeah.
Yeah,
So we'll have a reconfirmation and then go ahead.
sure. I'll do that.
Tentatively scheduled for next Friday, and
Yes, yes. I'll
we'll,
I'll confirm before sending out the flyer.
sure, sure. Thanks for
Thank
coordinating
you.
very well.
Thank you, sir.
Appreciate
Any questions from the participants?
Hello, myself, Dr. Shrikant, madam. I have one question.
Yeah.
Yes.
So this sulfadiazine is not available throughout the Bangalore, sir. We tried for one of the patient.
Yeah, Shweta should
Hello.
be able to answer this. Yeah, we are also not been able to procure that. Ma'am, we have this sodium oxazole with us, no? Yeah, we have that combination. Trimethoprim and sulfamethoxazole we have.
Yeah,
That's yeah.
in the situation we can use the cotrimoxazole. Sir.
That's all. Yes.
This one,
As I
because
mentioned, it's alternatively used.
yes. Okay. Thank you, sir.
Any more questions? Please feel free to unmute, or you can put your questions in the chat box. ARDC, Davangere, would you like to ask a question? So I don't think there are any questions. Thank you so much for facilitating this session. We look forward to the remaining part.
Okay, thanks.
Yeah.
So the remaining part is also as interesting as this part. So it will be nice to have a discussion on that. So.
Right. So just a second. Piyusha ma'am, would you like to come in?
Yes, ma'am, in the toxoplasmosis, we didn't get sulfadiazine, but we got the paramethamine plus sulfadoxine, madam. And one patient treated and it has been successful, madam. So, can sir tell about that one? Can give sulfadoxine also, no, instead of sulfadiazine. Hello?
Sir?
Yeah, we have not come across that kind of a combination, but as per the protocol, I don't think so, because there are two different kind of drugs. We're looking at sulfamethoxazole with trimethoprim combination, or with pyrimethamine and sulfadiazine.
Sir.
Yeah, on your own to do something like that, you'll be liable for
Yeah, so I've treated one patient with the paramethamine and sulfadoxine, and it has been successful, sir.
any studies done on that?
Only one case, sir.
Yeah. How did you initiate is the question, because there's no recommendation as such, no.
Sir, the tablet availability is only paramethamine sulfadoxine. Sulfadiazine is we didn't get it here locally, sir.
Oh.
It was not available anywhere, sir. Sulfadiazine.
Oh. Shweta, please make a note and discuss with the panel, and probably we'll see how far we can go on this.
Okay, sir. Thank you.
Thank you. Thanks for bringing it on notice.
Thank you, Piyusha ma'am. Any more questions or comments, suggestions?
Sir, one more question, sir.
Yes.
In new pre-applications with TB meningitis, sir.
Yeah.
We have to give 4 weeks. First, we start ATT and then give 4 weeks after ART
Yes.
after 4 weeks. So if it is CD4 is
Yes.
very less, sir, like if it is 20, 30, 40 like that.
Yeah.
In that case also, will it not result in more HIV viral load and HIV encephalopathy?
No. See, CD4 count is less because you have not initiated ART.
Sir.
So, because you're treating opportunistic infections and you concomitantly treat ART regimen, then it will lead to high risk. So, they have said
Hmm.
4 to 6 weeks of abstinence from ART regimen. Patient settles down with the acute OI infections and then
Yes.
you initiate with ART, right? So,
Yes.
your primary focus should be on avoiding iris and you have
But
to initiate
immunity will
ART.
be immunity will be going down very quickly, sir, at that time.
So immunity is going down very quickly. So you should not initiate ART. Is what is your question?
No. We the guidelines are that we should not initiate ART till 4 weeks.
Yeah.
But immunity, if it immunity is going very down, that will be a high risk, sir. Very, matlab,
No, I will not agree with you. So stick to the
hmm.
approach.
Okay, sir. Okay, thank you.
Thanks.
Yes, in case there are more questions, please feel to write to us or you can write to the COE directly. Thank you once again, sir. Thank you to all the participants for patient listening. We'll conclude this session now. Thank you, sir.
Thank you. No.
Thank you, Shweta.
Thank you, ma'am.
Uh, regarding guidelines in if it's CD4 is less than 50, simultaneously start ATT and
Yeah.